All right, good morning, everyone, and welcome to CMS Grand Rounds. Sherry Lang, Deputy Chief Medical Officer here at CMS, geriatrician, internist, rheumatologist. I'm actually really delighted to kick off 2020 with this critically important topic that really applies to all of us in some way, whether it's our parents, our family members. So really delighted that we have an all-star panel who will be bringing the latest cutting-edge information, no pun intended that it's surgical, but nonetheless really delighted that you are all joining us here today. We also have some of our guest clinicians from Johns Hopkins and other institutions around who are joining us for the day. So welcome to all and happy 2020. CMS Grand Rounds is something that we have been implementing for the past 8 years now. And it's our chance for us at CMS to gather together and to bring in our national experts to help us understand what the new evidence is that is emerging that is applicable to the care and keeping of the beneficiaries who we serve. So we have specific educational objectives that for today's session, by the end of this activity, you should be able to recognize symptoms, outcomes, other characteristics in older adult surgical patients who are our beneficiaries, identify some of the definitions that are really used to describe functional loss of independence, define the mission that our surgical colleagues from the American College of Surgeons actually is driving towards, which is better outcomes for the people who they serve, who are our beneficiaries, and identify some of the elements that are specific to improving geriatric surgical care. This actually aligns very well with the CMS Strategic Goals, which is the information which can be used for important conversations and decisions between clinicians and their patients, ushering in new era of state flexibility and local leadership. This is about not only national programs, but how we improve at a local and community level, to support innovative approaches to improving quality, accessibility, and affordability, and ultimately to also improve the CMS customer experience. And here, CMS customers are our beneficiaries and also the clinicians who we work with, we rely upon to provide the very best care to our beneficiaries. Today's event is eligible for CME credit, and this actually supports our overall educational efforts here at CMS. In order to claim CME and CEU credit, today's event, it will be included in our Medicare Learning Network as an enduring material or enduring materials. And you do need to register to be able into the learning network so that you can view the recording of today's session and also go in answering the questions, the evaluation questions correctly in order to claim credit. And this is the site that it is located. The information of the recording will be located. So just by way of an overarching disclosure statement, so what you will hear is the latest state-of-the-art information and evidence that our colleagues here are actually out there generating, but also because they are clinicians, this is all real life, relevant and important at the point of care, but this is not really predicting or forecasting CMS policy. This is for educational purposes. We will have an upcoming event in March. In February, we are hosting the CMS Quality Conference. So if you are interested, it is reasonably priced at free. So you just Google search CMS Quality Conference and register, and please join us there. It is being held in Baltimore, Maryland. And so with that, I would like to turn the podium over to my dear friend and colleague, Dr. Marian Couch. Dr. Couch is someone who really inspires us as clinicians for not only the work she has done as former chairman of 2 departments of surgery. She is an ENT surgeon by background, but also the critical role that she has played in our Office of the Administrator as a senior medical advisor, innovative in thought, practical in application. So really honored that Dr. Couch has joined us today. So with that, Marian, please welcome Dr. Couch.
Sherry, thank you. And thank you so much for organizing this conference and letting me be part of it. Her team with Wanda Travis and Patrick Wynn have really done a nice job of pulling a group of, I think, truly outstanding surgical leaders together. We're going to start with a talk by Dr. Ronnie Rosenthal, but if you don't mind, I'm going to introduce all the speakers. After the introduction, Dr. Rosenthal will come up, and then she'll be followed by Dr. Clifford Coe. Then we'll have a 30-minute lunch break, and then Dr. Daniel Hall, Dr. Jason Johanning, and Dr. Frank Opelka will be speaking to us as well. It's a grand rounds that is perfect timing for many of the issues we're thinking about within CMS and CCSQ, as we're constantly thinking about the best way to promote quality programs within CMS. So it's always a joy to be with really smart and special people, and every single speaker falls into that category. Dr. Ronnie Rosenthal is a professor of surgery at Yale and chief of surgery at Yale's VA. She's the chair of the American College of Surgeons Geriatric Surgery Task Force and co-leader of the ACS Geriatric Surgery Verification Program with her colleague, Dr. Coe. Dr. Clifford Coe has traveled across the country to join us today. He's a professor of surgery and a professor of health sciences at health services at UCLA. Within the American College of Surgeons, he's the director of the Division of Research and Optimal Patient Care. And in that role, he oversees the college's quality improvement programs. Dr. Frank Opelka has a short CV of 10 pages, and I'm going to have to just go for the highlights, but Dr. Opelka is the medical director of quality and health policy at the American College of Surgeons. He served on numerous committees within the National Quality Forum. He has launched the Surgical Quality Alliance with a number of surgical specialties. Prior to that, he was the System Executive Vice President and Health Centers Vice Chancellor at Louisiana State University, and I think they just won a football game or something. So also he worked in the Dean's office. Many other accomplishments, but he was very much involved in the response to Hurricane Katrina. He served as a Harvard Medical faculty as Vice Chair of Surgery at the Beth Israel Deaconess Medical Center, and also served in the military. So always a pleasure to work with Dr. Opelka. Dr. Daniel Hall joins us from UPMC, where he's medical director of high-risk populations and outcome for the Wolf Center at the University of Pittsburgh Medical Center. He's in the surgery program and is a core investigator at the VA Center for Healthcare Equity Research and Promotion. He also brings a very special background. He has degrees in medicine and theology from Yale University and is an ordained priest of the Episcopal Church and was also the first John Templeton Fellow in Religion and Medicine at Duke University, so very much involved in medical decision-making. And that perspective, I think, is always appreciated. Dr. Jason Johanning is a professor of surgery and is the Omaha Chief of Surgery at the VA Center there. He has completed a Health and Aging Policy Fellowship in Washington, D.C., where he worked with both the VA and CMS. And he continues to work as the Veterans Integrated Service Network for Chief Surgical Consultants and is the medical director of that program with multiple funding projects. And it's a pleasure to have all of you here. Again, I think this Grand Rounds comes at a pivotal time for all of us. The timing is perfect, and I think we'll all be very much interested in what our speakers have to say. So with that, Dr. Rosenthal, thank you.
Hi, good morning, and thank you, Dr. Ling and Dr. Couch, for giving us the opportunity to come and speak with you all today and to the whole CMS team. And we're going to speak to you today about our geriatric surgery verification project, which is designed to improve the care for older adults when surgery is in their care plan. And I do have one disclosure. This is sort of self-interest because I am a Medicare beneficiary, and so this is in my own best interest. So we all do know that the population is aging, and Dr. Ling told us this at our quality and safety meeting that 10,000 people apply to Medicare every day. And we know that by the end of this century, 1 in 5 people will be over 65. But the number that's most impressive to me is that by 2050, there'll be almost 50 million people in this country over the age of 85. And we know that the diseases that surgeons treat, like cardiovascular disease, cancer, and musculoskeletal disorders, are diseases of aging. And so we can anticipate a huge number of older adults who will need surgery. We do know that more than 50% of people over the age of 65 will have a surgical procedure in the remainder of their lifetime. And the current 15% of the population who's over 65 accounts for 40% of the procedures already, or 19 million procedures. Unfortunately, we also know that the overall traditional outcomes for surgery in older adults are worse, and also the surgical decision-making is often far, far more complex. So the one thing we can say about aging, and that we can say about all of the surgical issues surrounding aging, is that there is great variability. So for those who age successfully, you can be a gymnast at age 80 or a track star at age 90, and you have a lot of reserve. So if one of these two people were to need surgery, they have enough reserve to be able to stand that stress. But for people who age less well and become frail and are using their reserves just to maintain their daily lives in their homeostasis, for them the stress of surgery can be enough to really push them over the edge to organ decline and to mortality. So we look at these patients and we know that these patients are frail, but frailty is really a very, very complicated entity, or geriatric syndrome, and it's characterized by chronic undernutrition and loss of lean muscle mass, or sarcopenia, which causes decrease in strength and decrease in power and decreased mobility and activity. And it's complicated by diseases and drugs and by some changes in neuroendocrine regulation. And it is a very complicated entity. If you now think about the metabolic and inflammatory changes of surgery being superimposed on frailty, you can see that it requires an enormous amount of attention to detail to get frail older patients through a surgical experience with a good outcome. So we also know that older adults and frail older adults have complications that are different from the usual complications of MI and surgical site infection that we think about. They have more aspiration, they have more polypharmacy, many more drugs, they have under and malnutrition become much more prominent problems. There's deconditioning, fall-related injuries, pressure ulcers, and catheter-related UTIs. But the things that are most important, the complications that are most important to older adults that we don't or haven't in the past really looked closely at are the complications of delirium, cognitive decline, functional decline, and loss of independence. And in fact, when we asked our AARP colleagues what was most important to the older adults in their cohort, they said it was brain health and cognitive decline. And so these complications of cognitive decline and delirium are very stressful to patients and to their caregivers. And we know that, and these are data from our own geriatric pilot of the National Surgery Quality Improvement Program, NSQIP. And this data shows that for patients who become delirious, those are the ones in the orange bars, compared to the patients who don't become delirious in their hospitalization for their surgery, you can see there are much higher rates of post-discharge to an acute care facility, serious morbidity, and serious mortality. So these complications, delirium, is very distressing to the patient and the caregiver, but also very costly to the system. Each episode of delirium costs between $15,000 and $64,000 per patient. And if you can take delirium across the board, not just postoperative delirium, but all delirium, that costs a potential of $38 to $152 billion. And the thing that's most important is that 30% of postoperative delirium is preventable. And so if we can put programs in place to prevent this delirium, it will be good for patients and it will be good for the cost of the healthcare system. We also know that patients dread this idea of loss of independence and becoming more of a burden to their family. We looked from our own data about what happens to patients in the hospital and how do they lose independence. We defined loss of independence as a decrease in function, a decrease in mobility, and increased post-op care needs. And we can see that the first column is decreased function, about 25%, decreased mobility, about 30%, and then increased care needs, either going to post-acute care or needing home care needs, is much higher at about 45%. And what was most impressive about this was that 60% of patients have some loss of independence, and of those who do, 70% there's a 70% increased risk of readmission for those patients. And there's almost a seven-fold increase in death at 30 days after discharge. So we don't have data that says if we can help loss of independence, we'll improve this, but we do have data that says that if you improve mobility, you can improve outcomes. And so if we could do something to actually help patients not lose independence of the hospital, that might be very helpful too. There's also enormous variability in the outcome of surgery depending on where the patient gets the surgery. And this is from a study that looked at mortality from a number of procedures, with the light gray bars being those who are in the top 20, the hospitals that are in the top 20% of performance, and the dark bars being those that are in the lower 20%. And you can see that the mortality for things like, on the extreme, like esophagectomy and pancreatectomy, are 2 or 3 times higher, just depending on what hospital it is that you go to. And also from our own database from the geriatric pilot, we saw that these important complications for older adults, postoperative delirium and functional decline, are also vary according to the hospital. Each one of these lines is a single hospital that was in our geriatric pilot. And the hospitals on the extreme left are those who do better in terms of their delirium and functional decline rates, and the ones on the right are those who do worse in terms of their functional decline rate. So there are opportunities here for hospitals to be able to improve that care, and this is the first time that we're actually able to look at this and use these as quality improvement measures. We also know that, so it's variation in aging, there's variation in quality, there's also variation in how care is provided across the country. And this was from a study that looked at Medicare recipients who died in 2008, and they found that in the last year of life, almost 32% of patients had surgery in the last year of life. But what's most impressive about this study was the variation in in how surgery was offered. So in Gary, Indiana, 34% of people had surgery in the last year of life, but in Hawaii, it was only 11%. So the question was, why is this happening? And so people say, well, Hawaii is different. People have different attitudes about end of life. But in fact, this is from another study that looked at if those regional variations in end of life expenses for Medicare were caused by variations in people's attitudes towards end of life. And on the left side, there are a bunch of questions that have to do with attitudes towards end of life. And the light columns are the low spenders, and the dark columns are the high spenders. And you can see that there really is no difference where there's a lot of Medicare spending or a little Medicare spending in terms of the attitudes. So it isn't really the attitudes of the patients or the desires of the patients, it's sort of what is available. So you can say there's a lot of difference between Gary, Indiana, and Hawaii, and so that things might not be available in those two places. But in fact, there's a huge variation, even within 2 miles in one big city in New York. And I'm just going to give you this tell you a story of Dr. Katz. So Dr. Michael Katz is an academic pediatrician who traveled all over the world giving lectures. And at age 89, he was in Auckland giving an academic lecture, and he started to feel ill. And by the time he got home, traveling in the air and getting home to his apartment, he passed out, and his wife took him to wherever the ambulance took her to, which was one of the big academic centers in New York. And when he got there, they discovered that he had endocarditis, the infection of the inside of the heart with damage to his heart valves. They treated him with antibiotics, and his infection went away, but his heart valves were so badly damaged that he had a terrible heart failure and couldn't do more than really just get out of his bed. He couldn't go out of his house by himself, and he was very distressed. His wife said, couldn't he have surgery to repair his valves? And the doctor said, oh, no, surgery is not in his plan. His mortality would be too high if he had an operation. But because she was very savvy about the healthcare in New York, she went and spoke to some of her other colleagues, and they said, we have another hospital for you to go to. And he went to that hospital where they did what she called preoperative boot camp. They gave him nutrition, they gave him exercises to build him back up again, and then they did repair his heart valves. He spent 10 days in the hospital, went home, and did his rehab in his home, and recovered quite well. And the reason we know this story was because 2 years later, at age 91, he was reading the New York Times when it was covering the story about our GSV, and he contacted Dr. Koh and said, if you want to hear my story about the variability of care in a short distance, I'm happy to come. And so we had him come, and he came to our quality and safety meeting in July and told his story. And when we asked him, well, did people ask what was important to you? And he said, I could have shown them my frequent flyer mileage account, and they would have known it was what was important to me, but nobody asked. So for him, death was not as bad as being confined to his house the way he was. And he's not alone in that. This is from another study by Terry Freed, where she asked older patients what their preferences were for treatment if there could be an adverse outcome from that treatment. And the top two lines are a high burden intervention like surgery and a lower burden intervention like medications. And you can see that the likelihood of the adverse outcomes goes out to 50% before people drop off in their wanting that treatment. So death is not that bad in terms of if the result is going to be good. But if you look at the two lighter lines, which are low burden interventions and functional decline or cognitive decline, you can see those curves drop off much, much quicker. And so for some patients, to have a treatment that winds up making them functionally or cognitively decline is worse than taking the risk of death. So it's important that we ask the older adult what is important to them. And in fact, there are many conditions that are worse than death to older adults. And this is from another study that looked at several conditions and asked what is worse than death. The bottom bar, which is the darker one, is worse than death. And you can see that bowel and bladder incontinence, relying on a breathing machine and can't get out of bed, are things that are worse than death. So it's really important to have that discussion with patients so that they know, so that you know what it is that's important to them. So how can we help Dr. Katz and his wife know which one of those hospitals in New York he should have gone to be able to be sure that somebody had the discussion with him about what was important, and then helped him get to the point where he could have his surgery? So The American College of Surgeons, with the very generous support of the John A. Hartford Foundation, formed a coalition for quality in geriatric surgery with the goal of defining standards and developing a geriatric surgical verification program so that patients could tell which hospitals were the hospitals that were giving the care that was best for older adults. We wanted that care to be focused on patients' goals and preferences for better decision making. We wanted to standardize the preoperative evaluation to look for those components of frailty that needed to be addressed and that could identify patients at high risk for different outcomes so that that could be involved in the decision making. We wanted to protocolize interdisciplinary, and that's the big word there, interdisciplinary care to address vulnerabilities and prevent complications and decline. And we wanted to improve the transitions of care with better communication among providers and among patients and their caregivers. And so we put together a coalition of almost 58 different organizations representing patients and families, healthcare professionals from all types of professions, medical and surgical specialties, and advocacy and regulatory groups. So CMS was one of our stakeholders, and Aetna and Kaiser and several others, and many patients and family groups. And we gathered input from the stakeholders, and we asked them what was the current state and what they thought the ideal state should be, and everybody agreed that care was very siloed and that older patients needed special care, but they couldn't exactly decide what that special care consisted of. So we took their input, we looked at existing guidelines and did extensive literature reviews. We made 11 hospital visits, and we made many more targeted phone calls, and we came up with 308 standards. Now, we talked earlier about burden of regulatory things, and 308 standards is, there's nobody who would want an extra 308 standards to follow. But we asked our stakeholders to tell us whether these standards were in fact important. So we did a RAND UCLA modified appropriateness methodology. We took those 38 standards, we had experts, and our stakeholders were amazing. They reviewed all 308 of these standards. And first in one round by themselves, and then with a panel, we asked them whether the standards were valid and feasible, and then looked at a measure of agreement. And we found that all of the standards, nearly all of the standards were valid, but some weren't feasible because they presented an additional burden. So we then took those 308, we did a lot of internal work and got it down to 92, and then we sent it out to 15 hospitals and said, which ones are you doing already, and which ones do you think would be difficult to do? And using that feedback, we came up with 33 standards, which we then piloted at 8 hospitals, and we have one of our pilots in the audience with us today. And then through 5 more rounds of improvement, we came up with our final 30 standards. And of those 30 standards, 12 of them have to do with administration and leadership and governance of the program and data and research issues, and 18 have to do with clinical issues. And I just want to tell you what the clinical issues are, because that's a sort of an important structure, and then Dr. Koh will tell you how the whole program goes together. So these, the clinical standards divide into the section on goals and decision making, which we've already said is very important. And the standard says to discuss the treatment and overall healthcare goals, to get in the patient's own word what's important to them. It's important to me to be able to walk my dog. It's important to me to be able to go to my daughter's wedding. We also said that when we discussed the surgery, that we shouldn't just talk about the survival and symptoms, which we always do, how long you live, how will your symptoms be, but we also talk about what the function will be after the surgery, what the living situation, what might be, and what the burden of care would be for caregivers. We also asked for code status and advanced directives, identify a medical proxy, and discuss life-sustaining therapy for people who are going to be in the ICU. And then we made sure that we want to make sure that every patient has the opportunity to reaffirm that decision-making with some member of the surgical team so that they are confident that they've made the right decision. The next piece is the piece to identify those vulnerabilities or the high-risk characteristics, and those high-risk characteristics are age over 85, impaired cognition or delirium. And these are things that should be screened for in the preoperative assessment. And these are things that could be done in the hospital setting or could be done in the primary care setting, depending on what the structure of the healthcare system is. We screen for impaired function and mobility, malnutrition, undernutrition, difficulty swallowing to identify those patients at risk for aspiration, and palliative care needs. But what's also really important is that once we get all that information together and we've identified what the vulnerabilities are for the individual, that we make a care plan that addresses those vulnerabilities, and we have a multidisciplinary meeting about these high-risk patients to discuss all of the elements of their care and to be sure that everybody is on board with it. And that information has to be shared with the patient and their family, and also with the patient's who the patient identifies as their primary doctor. Postoperative management, we want to standardize the postoperative management. It's very difficult for older patients who have hearing and visual losses. When you're seeing them in the PACU or on the floor and they don't have their glasses and their hearing aids, it's hard for them to be able to tell you because they don't understand what you're talking about. We want to avoid drugs that we know are potentially cause problems for older adults, like the Beers medications, which can often cause delirium. We want to use opioid-sparing pain modalities so that we can limit the exposure of opioids for older adults. And we want to use protocolized plans like enhanced recovery or plans from the niche organization, which is Nurses in Care of Hospitalized Elders, protocols that actually make sure that every patient is getting the same kind of appropriate treatment for what the vulnerability is. Finally, there are the transition of care standards, which are also very, very important. One is what the discharge documentation looks like. So when we identify somebody preoperatively as having a deficit like a cognitive impairment or a functional impairment, we should make sure that on discharge, that information is going to be communicated and that there's a plan for how that deficit will be addressed. And we also want to make sure that older adults, families and caregivers and the patients have information about what the geriatric syndromes or the geriatric complications that they may be looking for postoperatively are. And finally, we want to make sure that we communicate with the post-acute care in a two-way fashion. We want to be sure that hospitals, when they send patients to post-acute care facilities, that they understand what the outcomes are in that post-acute care facility, and that they're aware of how their patients are going to be treated with where they're going, and that the communication goes two ways. So those are the standards. That's how we got there. And now, and this is our standards book. That's part of the program. And now Dr. Koh is going to tell you how the program actually works and how it's going to improve care.
Great. Well, thank you. Good morning, everybody, and thank you for the great invitation and opportunity to share some of this work with you. I think what Ronnie has told you is what the issues are, what the literature shows, what our 50-plus stakeholders have told us are the important issues of taking care of older adults undergoing surgery, and really why we should be addressing this, what the opportunities are. What I'd now like to share with you is how. How, if your family member, a friend needs to have surgery, how can you be sure that they're going to have optimal care? How, in the United States, that we can ensure as best as possible to raise the tide, lift all boats, that whichever hospital somebody goes to, that they would have optimal care if they're an older adult. Ronnie shared with you the evidence, the great experts telling us what are the important things, and I'd like to share now with you how we plan to do this. How does this work? So I work at the American College of Surgeons, and the American College of Surgeons is the largest professional organization for surgeons in the world. And one of the benefits of working with the college is its dedication to quality. And this is the mission statement of the college. And the first part is apropos to what we're trying to do, is to improve the care of the surgical patient. The college has probably about 400 staff, and over half of the staff works on a quality program. So the college is very dedicated to that, and it has a lot of people working on the quality programs. The college has been in existence over 100 years, and I show this not to show these people who were in the beginning stages of the college, who I'm not sure who they are, but the programs themselves. And to say that the college has a lot of experience in putting programs together, developing programs, and putting them out into the world to help improve care. So some of the programs are the Commission on Cancer, for obviously cancer care, the trauma program, if a level 1, 2, 3 trauma program, that's a program of the college. The NSQIP programs, a bariatric program, a pediatric surgery program, and all these others that are newer and are in development. What the college has done is either see, hear, analyze where gaps are in care, where opportunities are, and we've subsequently developed programs. And so you can see here in the blue boxes here, high-risk GI surgery, vascular, thoracic, emergency general surgery, and surgery in the rural areas are our latest programs that are being developed because of our opportunities in these areas. Now, this is a map that's a little difficult to see, but each one of those dots is a hospital that belongs to at least these 5 programs, and there are about 3,000 hospitals in the United States that belong to at least one of the college programs. Frequently, these hospitals have more than one, and so there are all types of sizes and bed size or physical size, urban, rural, anything in between, teaching, non-teaching, there's all these other characteristics, and increasingly more, there are hospital systems that are participating in this. Now, the geriatric program, the Geriatric Surgery Verification Program, is, as you would guess, applicable to all types of different hospitals and different settings. All hospitals are taking care of older adults, and all hospitals have this opportunity to get better in what they're doing, and largely the things that Ronnie shared with are things that are key for these hospitals to concentrate on. Now, the majority of the ACS quality improvement programs have 4 elements, and this is very important for us because this is our model of the way we have done things, and we think that this really works. The first element is our standards, setting standards. So getting together a whole bunch of experts, as Ronnie has done, a whole bunch of stakeholders, combing the literature to see where the great literature is, and putting together standards of the standards that should be met. They are based on the highest evidence, they're clinical, and they're individualized to the patient. And so that's very important as we're trying to get precision healthcare, precision medicine, and patient-focused, that these standards kind of keep the focus on the patients. In order to do this, in order to give great care, one of the areas that I think that has been overlooked wrongly is the infrastructure needed to provide the care. A lot of times we say, perform on this metric. We study to the test, we kind of do that, but we don't have the infrastructure a lot of times to kind of do it continuously and consistently. So as part of this program, of all of our programs, is what is the infrastructure is needed? So the people, the organizational management, the protocols, all of these things putting together, which are the infrastructure and the basic foundation of the care that we provide for the programs. Clearly, data is really important, and having good data is very important based on the VA, and now with the American College of Surgeons and NSQIP, we know that risk-adjusted outcomes, clinical data that are audited, that are very high level and meaningful, and something that is actionable by the users is clearly very important. And finally, verify through a third party. So just because people say they give good care, which I think everyone really means to give good care, verifying that these standards are met, that the infrastructure is there, that people are using the data, that they're performing, verifying by a third party is clearly important. It leads to public assurance. It leads to places knowing, having some level of introspection and self-awareness of like, oh, we're not as good as perhaps we could be. And so how do we do that? So these 4 elements are the key parts to what a verification program is at the College of Surgeons. And so if we talk about geriatric surgery verification, these are some of the standards, many of them that Ronnie talked about. This is some of the infrastructure in terms of the people, the physical items, the protocols, and you can see that the people are really important. It's not just physicians, but nurses are very key. Pharmacy, OT, PT, leadership, and the fact that it's a multidisciplinary team. That is the key part. And it's not just the individual, but how the team works together. One of the standards that the stakeholders told us is that you just can't have this person, this person, this person, and just kind of just individually giving consultant information, but really doing it together in a discussion leads to greater insights by the whole team and probably better care for the patient. So this interdisciplinary, multidisciplinary piece is really important. Data, clearly, delirium, and a lot of the things that we're already measuring, falls and readmission, are very important, and then verification. I put in here pass-fail and a versus a 1 to 5 scoring because a lot of times people ask, like, well, is it a pass-fail? Is it like school where I'd love to be pass-fail, or is it a 1 to 5, kind of like a grading? We really believe that quality is a journey. And you just don't get a pass and then you're done with it, which we see in a lot of programs that are pass-fail. You get across the line and you just kind of finish it and you don't think about it until perhaps the next visit. This is a journey. This needs to be continuously rolling the rock uphill. It is continuously perseverated on. This is continuously something that we need to have at the forefront as a priority that we do every single day we're taking care of a patient. The scoring gives us this ability to see that we're making progress or not making progress, or where we stand and where we can get to. So a lot of times our programs now are going to the scoring not as a punitive or not as a punishment, but really to let people know that this is the spectrum and this is the journey, and the short game and the long game is really getting to the highest score possible. So some real nuts and bolts about the geriatric surgery verification program is that there's a level 1 verification, and this is a comprehensive excellence. And this is so the hospital, if you can imagine a hospital having all types of surgery where they take care of older adults, like orthopedics and urology and general surgery and otolaryngology and all of these. If the hospital, by and large, the whole hospital can take care of older adults and meets these standards for the majority of the hospital, that is going to be a comprehensive excellence level 1 hospital. If a hospital is starting out and they can't do the majority or more than 50% of them, but they can do a smaller part but do it very well, this is a level 2, and it's focused excellence. And so that's basically the difference between a level 1 and level 2. Now we know that while taking care of older adults is really, really key and a priority, a lot of hospitals are not ready for this. They are not kind of have all of the standards and infrastructure in place, and they don't have the data systems in place to do that. And so we have this level called the commitment level, and it's basically a hospital just makes a commitment. It's like, yes, we want to get better in taking care of older adults. We have that commitment there. And our leaders and our people on the front lines and our people in the middle have this commitment, they want to do it. And so this is the commitment level. And basically what it is up to a 2-year journey to getting to a verified level. And so we have a lot of things that we help and we've prepared to help hospitals build and develop and create and sustain a geriatric program. And so again, there's the verification piece for level 1, level 2, but I really want to concentrate on the commitment level here. The commitment level over the course of 2 years, and if a hospital can do it quicker, great. But over the course of a 2-year program, there is a commitment and there are 10 modules, and you could see them here, I won't read them, but they're different pieces of the standards of the program. And so if a hospital's, we're like, how would I do 30 of these things, and how do I get this in, and it's chaos and whatnot. In a very structured way, we have put together PowerPoints and webinars and video conference calls, and we have case studies and best practices from places that have put these things into play and telling hospitals, all right, how do I get institutional commitment? How do I do number 7, transitions of care, and how have leaders done that? How's a hospital that looks like mine achieve these things in education and surgical decision making? How do we know that we're doing it well, and how is a hospital that is doing it really well, how have they implemented it? So this is a way that we know that when we kind of look at the landscape of hospitals that might not be ready for verification, many are, but some aren't, and so this is a kind of a training program for the creation of this called the commitment level, and it is very structured in the way that it is brought out there. So I talked about the college programs and the 4 elements of this. Does it work? Does standards, infrastructure, data, and verification work? And so let me share with you 3 of our programs, these 4 elements. Let me share with you 3 of these programs: the trauma program, the trauma verification program, the bariatric surgery program, which actually started with CMS almost a decade ago in a NCD, a coverage decision program where bariatric centers needed to be put in place, and breast centers, which we found out probably about 10 years ago that there's a whole bunch of places that just called themselves a breast center: Joe's Breast Center, Bob's Breast Center, Jane's Breast Center, but how many of them actually did what a breast center should be doing? And so, and then I'll talk about a little bit about our database in NSQIP. So, the trauma program, this was a study that was published in the New England Journal several years ago, and it really looked at the effect of a breast center or a trauma center, a verified trauma center giving care. Do they decrease mortality in people who have had trauma? So this is very difficult to see, but hopefully this makes it easier. If you look at trauma centers and non-trauma centers, and the overall population that come in the door of a trauma or a non-trauma center, and then maximal injury score, which are the highest level of injury of a trauma patient. And you can see that the death, in-hospital death, and it's death 30 days, 90 days, and 365, but I'm just looking at the death in the hospital, there's a decrease from a relative risk of 0.8. So a 20% decrease if you go to a verified level 1 or 2 trauma center. If you look at the highest injured patients, or the people who have the highest severity of injury for a trauma patient, that's a relative risk of 0.7. So almost a 30% decrease in mortality in a trauma patient. That makes a difference. If somebody were injured, if your family member were in a car accident, you would want to go to a level 1 trauma center. And that's what happens nowadays. It's set up so that the injury, the ambulances and whatnot will go to the closest level 1 trauma center, or level 2, or whatever the closest trauma center is. This is the setup. This trauma program has been in existence for decades, where standards for a trauma center, the infrastructure needed for a trauma center. I can't tell you the number of multidisciplinary trauma conferences we have at our hospital because of this verification program of standards and infrastructure that are needed. NAPBC is the National Accreditation Program for Breast Centers, as I was talking about before we instituted this program. When we looked at it, it was kind of the wild, wild west. There was a lot of variability, no data, no standards, no nothing. And after we put this into play, these are just a few papers that have been published in the last several years. And you can look at this chart where there's something that favors non-centers and something that favors centers. And these are the performance measures, and these are very difficult to read, but this is basically using chemotherapy when it's appropriate, using other types of chemotherapy when it's appropriate, surgery and needle biopsy, and all these performance measures in taking care of breast care. This is how we measure the quality of breast care. It's not always the outcomes, because a lot of times you have to do 5, 10, 20-year survivals. Not only that, but a lot of the things that we do. And when we measure these important processes in cancer care and breast care, there's a lot of variability, and this needs to get better. But you can see here in the favors, the breast centers, is that in every single one of these, it's statistical that these centers do better. These centers give better care. And a lot of it has to do with the standards and the infrastructure and the organizational management that's in place in these centers. And without that structure and without that infrastructure and those foundational pieces, That disorganization leads to people not getting chemo when they should, leads to people not getting a biopsy appropriately when they should. And so these things in place helps a facility, a breast center, get better scores on these things and in a statistical way. And this has been shown in multiple studies. Lastly is the NSQIP, the Metabolic and Bariatric Surgery Program. Again, this is a verification program. There are probably 900 of them in the country. Over 90% of the bariatric surgery is done in this. But before it was getting to that level, you can see here, let me see if I've put these, there's increased mortality in non-centers, kind of like the trauma program. People don't do as well when there's not the standards, the infrastructure, the data, and the verification piece. And you can see that unaccredited or unverified versus verified centers, the verified centers spend less money, they have less complications, they have lower mortality, they have better failure to rescue. And so in a center that, again, has the 4 elements, better care is delivered, better care processes, better care outcomes, and largely because of the standards, the infrastructures in place. So just like Donna Beating said, structure, process, and outcomes. Largely in quality, we have kind of gone process and then outcomes, and have kind of largely skipped over the structure that's needed. And what we find is that studying to the test, we can get good scores by, however we do it. But without the infrastructure there, it is not going to be consistent. And if we change the questions on the test, we have to reconfigure this. But if we have the structure there, we should get questions right on the whole test, regardless of what the questions are. So again, the 4 elements are key. One of the last things is that we need to have good data. And this is shown with a lot of great databases, whether it's the college's NSQIP or STS database or all these others. And here, hospitals that really knew how to use the data, they improved, 82% of them improved in decreasing their complication rate, and 2/3 improved in their mortality rate. They decreased their mortality rate. So we know that good data is clearly important, and that's a no-brainer for everybody. So in terms of the geriatric surgery verification program that has the standards that Ronnie shared with you, that has the infrastructure that's needed to provide optimal care to the older adult, having data to tell us how we're doing, and then verification through a third party to have assurance that these things are being met, is the model that we're using for this verification program, this geriatric program. So in summary, it seems that there's a lot of aligned opportunities by this geriatric program and with CMS. CMS is the largest purchaser of health care in the world, with 10,000 new beneficiaries daily, which is what Sherry and Ronnie both had shared with you earlier. The 85-year-old population will increase by almost 200% by 2050. And as we get more advanced in our technology and our knowledge of surgery or healthcare overall, we are taking care of these patients increasingly more in the operating room and undergoing surgery. Increasing number of older adults are undergoing surgery, as we just said. And finally, there's demonstrable opportunities for improving care and outcomes for this population. Every study we do that looks at the elderly, the older adults, shows that they get worse care, worse outcomes, worse processes. We really need to kind of address this. I know that a lot of people are like, oh, it's just, under the drapes, everyone looks the same. I do the same operation, but there's clearly things we have to do differently when we're operating. There's clearly different things we need to do before we get to the operating room, or decide we might not have to get to the operating room or should not get to the operating room, and afterwards, after it in the hospital and post-acute care as well. So we really believe that this 4-part model used in our quality programs will help to achieve better care and outcomes. Thank you very much for your attention. If there's any questions, I think we're going to answer them after lunch, but thank you very much.
Thank you, Dr. Coe and Dr. Rosenthal. I do think we have time for a couple of questions. Does anyone have, is that right?
Yeah, I think we have about time for one question. We do need to end promptly at 12 o'clock to give everybody time to have lunch and be back for part 2. at 12:25 because we will start promptly at 12:30. So with that being said, I think we have about time for one question.
Thank you, first of all, for you guys for being here. And all right, I can't get heard on the phone, obviously. Thank you, all of you, for being here in the incredible work that you're doing. So, Cliff, we really agree that infrastructure is important, but as we've developed measures, as you know, most of them are outcomes, some are process. They've started as process, they move to outcome, and we don't do a lot of what we would call structural measures around infrastructure. Philosophically, should we go there, or do we just turn to the specialty societies and say they're the ones who can help you develop what infrastructure should be?
So, great question. Thank you. Thanks, Michelle. So, I think that's what's needed to sustain high optimal process and outcomes is the infrastructure. Your question is, should the college and other organizations put those into place and people follow, or should it be a collaborative effort of a whole bunch of groups? And my feeling is that it should be a collaborative effort of a whole bunch of groups. Having that aligned so that a hospital sees that, all right, it's not here, but really one set of things that we should be doing, structure, process, and outcomes, is a much more feasible, understandable, messageable way of addressing these things.
Just a quick question. In your commitment levels, I was wondering about postoperative care, which I didn't see up there, if that's something that you also ask the hospitals to address, thinking about pain, like things like pain, community resources. It just seemed like a missing category.
Yes, so I think we have this module of perioperative care, so that includes pre, intra, and post. So our perioperative module, it will include that. And yes, absolutely, the pain issue is a huge one in older adults, and we spend a lot of time and have a lot of materials in that aspect.
Okay, we'd like to thank Dr. Rosenthal and Dr. Koh for their fantastic presentations, but remember, we have a part 2 coming up, so get nourished. Be back here promptly at 12:30. We'll get rolling, and we'll have another great presentation by Dr. Hall, Dr. Johanning, and Dr. Opelka. Thank you, everybody, for joining.